All right. Welcome, everybody. Thank you so much for joining us today on this week's episode of Weekly Dose with Dr. Ude. I have a treat for you. I have Dr. Mehra here with us, and we're going to be talking PCOS. So, before I get into all of that great information that we're about to have, I'm going to introduce myself. For those that don't know me, my name is Dr. Ude. I'm a board certified family medicine physician. I'm based in Martinsburg, West Virginia. I have a primary care practice, namely Apple Valley Family Medicine, and I also have an aesthetic practice. My goal is to have my patients not only feeling good, but looking good. So let's get right into it. So I have Dr. Mehra here today. So I'm going to give you some information on Dr. Mehra. So Dr. Mehra is a board certified pediatric endocrinologist offering medical care for children aged 10 to 21. She practiced for the last 15 years in the DC metro area, both at Children's National Medical Center and at Pediatric Specialist of Virginia, where she was the medical director of pediatric endocrinology. She has a specialization in treating menstrual and hormonal conditions in girls and young women. Dr. Mehra now offers consultations and follow-up care for a variety of endocrine issues. And with all this, Dr. Mehra took the time to spend with us today. So thank you so much, Dr. Mehra.
Sure, you're welcome. Happy to be here.
Okay. So first question, we're going to get right into it. What is PCOS from your perspective?
Yeah, so PCOS, and first of all, I want to start off by saying that PCOS stands for polycystic ovarian syndrome, and it's actually a terrible name for the condition. And people come to me all the time scared that they have cysts on their ovaries, and that's actually not what it means. PCOS as a condition really is defined by irregular menstrual cycles, so your periods can be irregular, signs on your body or in your lab test that show that you have an elevated level of a hormone called testosterone, or you have hair on places that women don't want to have hair. So, hair on the upper lip, chin, chest, stomach, lower back. And we really look at it and ask our patients, where do they have the hair? So, those two things, periods and irregular cycles, help us define the diagnosis. Now, in pediatrics, we often don't rely on the ultrasound, but the Androgen Excess Society and the Endocrine Society and the NIH guidelines and the Rotterdam guidelines do say that you can do an ultrasound, and if the ultrasound looks like there are what looks like a ring of pearls on the ovaries, that can also define PCOS. But you need to have two out of those three. And in pediatrics, I usually look at irregular cycles or signs of hair where women don't want to have hair, or a hormone level that's elevated. And that's what I look at to diagnose the condition.
That is a
Um,
great definition. Absolutely. I'm sorry. Were you going to say something else?
sure, yeah. And the other part I wanted to say is, um, does not mean that you have cysts on your ovaries. Not everybody that has the condition has cysts. If you do have cysts, they may go away because we all get cysts at, each cycle. So it's really not something that you need to be terrified about. And that's often what people are worried about when they hear that diagnosis.
Gotcha. So, what would you say causes this? Is there a genetic predisposition to it? Because a lot of times patients are like, what did I do to get it? So that's why I'm asking that question.
Yeah, so the number one cause of PCOS is genetics. And so there have been studies that have shown that if a mother has PCOS, 90% of her daughters will have PCOS. So, and if a sister has PCOS, 90% of the time her sister will have PCOS as well. So it tends to run in families. It also tends to run in families um, of children who have parents who have type 2 diabetes, because PCOS is associated with type 2 diabetes and risk factors for type 2 diabetes. So, usually there's a history in the family of somebody with diabetes or somebody with polycystic ovarian syndrome. Rarely we see it that it just sort of comes on that your cycles are irregular. Sometimes with excess weight gain, you can develop irregularities in your menstrual cycles. But most of the time, there's a genetic component for PCOS.
Gotcha. So you kind of touched on it because usually I kind of separate it and say, hey, here are the symptoms and here
Mhm.
this, but it looks like those two are kind of tied in because the symptoms is how you use to diagnose it. But can you?
Exactly, exactly. And when I have patients come to see me, so when we talk about pediatric PCOS, and I always say pediatrics is not, we're not little adults, so that we treat, but pediatric PCOS, we really have to look at the menstrual period 2 years after their periods start. So, like the first 2 years after their periods start, periods can be normal. And the other part, Dr. Uday, is that um, periods don't have to be every 28 days, and I get that question a lot. Like, "I don't have a period every 28 days." No, almost nobody has a period every 28 days. If you do have a period every 28 days, you're lucky. So, you could have a period everywhere from any 21 days to every 45 days, and that's normal. And for kids, the first 2 years after they get their periods are gonna be all over the place, and they can be pretty irregular, and I don't worry about it then. It's really after that time point. So after 2 years, keep track of their periods. If they're irregular outside of that window, then we start talking about, is this PCOS?
Gotcha. So, formally with diagnosis, I know you kind of mentioned it. You look at the symptoms, and then is there anything else you do to diagnose?
Yes. So I do a pretty comprehensive evaluation. I have worked with the adolescent gynecologist for the last 15 years, and I really learned a lot from adolescent gynecologists. But I do a whole evaluation. We talk about, periods, the hair growth, and there's a scoring system that I use to see how much hair you have. So if you have a little bit of hair on your upper lip, that probably doesn't qualify. But we really look at, your physical exam. Really self-reported information is also important. Like, how often do you remove hair on your face? Are you removing hair on your face every week? Are you shaving? Are you cutting? How often, cutting it? How often do you do that? So we do a pretty comprehensive evaluation. Usually that's enough. If you tell me that you're removing hair and shaving, once a week or every other day, and your periods are irregular, that's usually enough to say, hey, you probably have PCOS. And the interesting thing is that 1 in 10 women have this. And women like me, and I'm from India originally, South Asian, 1 in 5 have PCOS. So it's very common.
Right.
And so, we look at, really what the, genetics are. I ask about a lot of family history issues, anybody in your family with irregular cycles, anybody in your family who has infertility or had a hard time getting pregnant, because we don't talk about that much in peds, but in adults, that's a real concern that your cycles are irregular and you can't get pregnant. So a lot of it honestly is based on history.
Right.
And then, the hair pattern growth, and then I do some labs to verify to see if they have PCOS.
Gotcha.
And I care about it, because there's a risk of diabetes, and
Mhm.
I don't want my teen, girls who I treat to develop diabetes. And so we really talk about it. We talk a lot about lifestyle, counseling, exercise. I actually, got my obesity board medicine certification because of that, because I was doing so much counseling on diet and exercise for my PCOS patients. But it's very important for them to know. And then we talk a lot about, you know, um, what it means, and like you just asked me, what brought it on, and usually it's nothing that they brought on themselves. It's nothing that they need to blame themselves for, or that the moms need to blame themselves for, because it's not something that anyone did to bring it on.
Gotcha. So you kind of touched on it, but formally, what is the treatment for it?
So really the treatment is focused on your symptoms, right? So once we have the diagnosis, we focus on your symptoms. Do you have irregular periods? What do we want to do for that? If your periods, I actually tell my pediatric patients that I don't even think you need to have a period every month. I mean, it's important for us to track that, but if you're having a period at least every 4 months or every 3 months, it's probably okay to start off with. So if you're okay with having a period every 3 months, that's okay. As long as you're having 4 periods a year, I don't have a problem waiting to see what happens, because PCOS in adolescents can evolve over time, and that can change. But if you are also having, heavy periods, or you don't know when your period's going to come, and you feel like, you're having less periods than, every 3 months, then we do talk about birth control pills. I mean, that's an option that we talk about. And people don't like to hear the word birth control pill.
Right.
And there's a lot of information and counseling we talk to with our moms, and culturally there are issues related to that. So we talk to our moms about that, and the kids, the adolescent girls. I don't want to call them kids, but we talk about that. And so, we say, is that an option? There's other medications besides birth control pills. I use Provera to sometimes bring the menstrual period on. So there's a pill that's not estrogen based that we talk about using that every 3 to 4 months to bring a period on. Um, I use a medication called metformin also for select patients, which is given for diabetes. And so if I think a girl has, I do test for their blood sugars. And so the A1C, if their A1C is elevated, I will try metformin. Or if they don't want to use birth control pills, we will try that, because at certain doses, metformin can be effective to bring your period on and prevent diabetes. Um, and then we also talk a lot about lifestyle intervention. um, Medication sometimes that we can give to help with weight loss, if that's an option down the road. But a lot of it is the symptoms. So people are worried about their periods, and then the other part that they're worried about, where you come in probably, is the aesthetic part of it. Um, is they're worried about this hair, the hair that they have, hair on their face, acne. What do we do about that? How do we treat it? Um, and we really talk about, that. And unfortunately, I don't have a good solution for the hair growth. I give certain medications to slow how fast that hair comes out on their face. It helps with acne. um, but laser or electrolysis sometimes is the only option to get rid of that hair. And for pediatric patients, I have a couple of places here in the Northern Virginia area, laser centers, that are willing to do laser and electrolysis for young patients. And those are the only things that have been truly effective over the long term, but they're expensive, and they don't, insurance doesn't cover them. But those are really the mainstays of treatment that we talk about.
Yeah, that's a good point. So yeah, I do quite a bit of laser hair removal for that.
Okay.
So that's
Okay. Yeah.
Mhm. So guys, you've heard it. So there is treatment out there to help combat PCOS. Now, Doc, I'm going to switch gears, and this is a question for you. I always ask, why do you do what you do?
So I do what I do because I grew up um, with irregular menstrual cycles myself. And so my periods were irregular, and nobody ever really paid attention to my cycles. And when I went into pediatrics, I started seeing a lot of girls who had similar concerns to what I had growing up. And I really wanted to tailor my practice to treat those patients and to provide them education. And then over the last 15 years, I've been seeing PCOS patients. I started a PCOS clinic right out of fellowship, so 2008. I started one, and then I saw that there were all these patients who didn't know what their diagnosis was, who were scared about their diagnosis, who didn't know how to get it treated, who didn't have the information, and they didn't really have anyone to go. I mean, adult OBGYNs do not want to see the pediatric patients. Um, Pediatricians often, were limited in time to do the full evaluation. And so I really, felt that I wanted these girls to be empowered to take care of themselves and to understand their diagnosis. And so I primarily focus on PCOS now in my practice.
I mean, that's very, the work you do, that's very important. And it sounds like you had some personal experience yourself,
Right,
and you knew exactly how it felt not to be able to get that care.
right,
So
exactly.
yeah, so very much appreciated. Thank you so much for what you do. So, if people are trying to find you or connect with you or find out more about you, where can they find you, Doc?
Sure, yeah. So I am located in Virginia. I have a primarily telemedicine practice where I see patients Virginia, Maryland, and Florida. And my website is www.TheMehraClinic.com. So my last name is TheMehraClinic.com. And I'm on Facebook and Instagram as well. So you can reach out to me, ask questions. And certainly for your patients in West Virginia, if they're willing to drive over the West Virginia line to Virginia, I'd be happy to see them via telemedicine as well.
We definitely need the help. So, guys, I will include that information with this video as well. Dr. Mehra, thank you so much. This was so helpful.
Sure.
So
Thank you for having me. This was great.
you're welcome. Thank you so much. So, guys, you heard it. So, I'm going to be including the information with this. And in addition to that, if you're looking for a great primary care physician, we're accepting new patients at Apple Valley Family Medicine. You can call us at 304-350-1087. And you can find us online at www.applevalleyfamilymed.com. Please like this video and please share it with someone that this could help, because I know this can help a lot of people. And thank you so much for tuning in, guys. This is all we have for you today. Thanks again. See you, Dr. Mehra.
Thank you.
Bye.
Bye. Bye.